Hello and welcome to SleepView's webinar, How to Partner with a Mail Order HST Company to Grow Your Sleep Lab. SleepView is pleased to be here with three esteemed speakers, Tammy Sterner, Loretta, Colvin, and Wendy Smith. After the three presentations, we'll answer your questions. Submit your mail order HST questions anytime via the Q&A box on your screen. The slide deck is available for PDF download in the handout section of your control panel. The webinar is free for attendees, courtesy of sponsorship by CleveMed and Itamar Medical. For a certificate of attendance, which is available for the live webinar only, you must meet a few criteria. You must watch the webinar on its original air date of December 19th at about 11 a.m. Pacific time for at least 60 minutes. You must complete the course evaluation, which will appear on your screen at the end of the webinar or when you personally leave the event, whichever is earlier. Even if you don't need a certificate, we'd appreciate it if you'd give us your feedback via the evaluation. If you're watching as a team, you need to each register separately now if every team member wants their own certificate. Everyone who meets these criteria will receive a certificate in their email within the next 30 days. For AAST members only, we will also submit your one continuing education credit directly to AAST. If you don't get a certificate within 30 days and you think you meet the criteria, you can email sroy@medcore.com. Today's webinar is being recorded and you will receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on GoToWebinar for the next 3 months, but the recorded version isn't eligible for the certificate of attendance. I am now pleased to introduce Tammy Sterner, RN, BSN, MED, NEBC. Tammy Sterner is the Administrative Director of Sleep Services at WellStar Health, an integrated health system, serving communities in central Pennsylvania and northern Maryland. Tammy previously worked 20 years as a registered critical care nurse, primarily at Lancaster Regional Medical Center and Penn State Hershey Medical Center. Her career at WellSpan began in 2003, covering a span of 17 years, and most recently serving as Clinical Director of Heart and Vascular Services at York Hospital. Welcome, Tammy.
Hi, thanks, Sheree, for the introduction. My role here at WellSpan is designed for facilitation and integration of sleep services. I started this role around 2016, and my background, as you said, is a registered nurse in bedside critical care. And later, I learned that there was a sleep opportunity to develop our sleep systems here at WellSpan Health in 2016. So I took that opportunity to learn more about what was happening in the world of sleep at WellSpan. So we are a integrated health system serving South Central Pennsylvania with a network of providers of 1,800 physicians and APCs. We have numerous hospitals, healthcare centers, and much, much more. We are a 6 sleep center system, with those being inpatient center beds, approximately 34 spreading across Adams, York, Lancaster, Lebanon, and Franklin counties. Is everything, can you see my slides okay? Is everything progressing? Good. All right. So we began our journey in advancing our home sleep program in approximately 2015. The journey into our home sleep testing world began prior to me joining our team, and we had average monthly home sleep test volumes in the teens. So we were not, by any stretch of the imagination, at meeting any kind of home sleep study demand at that time. To the time when I began investigating our options, we set what we thought was hitting our stretch goal of 100 studies per month among 4 to 5 sleep centers. That was exciting at that time, and we didn't understand a lot about our business at that time, why we weren't growing and what we needed to do to grow. So one of the, I guess, advantages that I saw as not having a sleep background was that I could ask a lot of questions as to why we were doing it this way. what was the reason we were using particular home sleep devices. And there was no preconceived idea about people, process, or our equipment and the way things had always been done. So I asked a lot of questions in an effort to understand the current state and what problem we were trying to solve. And I remember the first time that I saw a wristwatch-like device in one of our sleep centers and asked what that was, because it was very different than some of our other devices we were using. It looked a lot simpler, and we were having some issues at the time, which I'll talk about a little bit later in some of my slides, that we weren't delivering the same standard of care to our patients across the health system. We were using different devices in different locations and even following some different standards of care.
Tammy, this is Sri. I apologize for interrupting, but I wanted to alert you that we're still seeing the first slide, the setting. Have you been moving your slides? And if you're having trouble, I'm happy to move them as well.
So maybe, can I give you the opportunity to take over that? Or
yes, keep talking, and then I will, I will move your slides, no problem. Okay, proceed.
That would be great. And so I advanced to slide 3, and that was more talking about how we got to the volume and starting status. So good, thank you. So the beauty, as I said, was not having a preconceived idea of the way we are doing things previous to joining the team. And without a background in sleep, I was asked to, it was great to be able to ask a lot of questions. And the first time I saw what looked like a wristwatch on one of our sleep center waiting areas, I learned that was a different way of providing the same service, and we needed to investigate further. It looked a lot simpler, and one of the concerns that we were hearing from our customers was that the devices we were using was very difficult to use. Physicians were looking other places for a service for their patients that was much simpler. So again, just asking the way we did things prompted a lot more questions. So next slide, please. So fast forward to our current state, we recently launched a direct ship home sleep study program in January of 2019. And as I had mentioned, we were at 100, if we were lucky, in 2016 to now over 467 studies is where we hit in our most recent month since January. And our in-center studies have been stable with the onset of increasing volumes in home sleep. But the beauty of this is that we're reaching more patients a lot faster. And now that we have an established, well-run program, our ability to expand has been limitless. We have experienced additional growth of 75% since January. And overall, you're looking at over 3 times since we started this journey in 2016. So the opportunities, want to talk a bit about that. It's actually a great problem to have, and working with the PCP communities and all of our specialties to incorporate and integrate care for sleep has been amazing. Our customers now are telling us that our services are easy to use, easily accessible, and at some point we will even be virtual, whereby a patient or a physician doesn't need to leave their home or their office to deliver that care. So next slide, please. One of the first improvements that we realized with using our new HST device, which is now the watch pad, we had been using the standard, respiratory type of effort belts with the oxygen and the finger probe. We now just have a simple wristwatch-like device that we put on our patients, and our failure rates of our HSTs have gone from 20% down to 1 to 2%, which is great because we were taking up to 3 days for our patients to have their home test, and the resource demand was great on both people and equipment for sure. So with reviewing the 40-some HST devices on the market, we landed on the WatchPet for a number of reasons. Number one, it best met the need for ease of use. The speed to be able to get to patients. We automated our scoring processes, which gave our techs a lot more time to do more value-added work, for sure, was definitely a plus. And additionally, it allowed us scalability, which I think today with the importance sleep plays in so many comorbid conditions is a huge asset to us. And again, at the end of the day, the people that we see as our customers, which is our physician partners and our patients, are much more happier using a device that's easy to use. And we were able to partner with ITMR and tackle this in a way that in the past, in the traditional way of capital procurement, we were unable to do. So next slide, which is the first, I'm sorry, you've got it. Yeah, scoring, you're fine. You can go back to the first improvement, which is our scoring. Techs were now doing much more value-added work, like working with our patients on compliance and those type of things that we needed to be doing versus sitting and scoring studies for hours on end and spending a lot of time in appointments with patients. They now can spend that time differently. So that was an adjustment, but the buy-in came when they saw the improvement of our quality results, the less time that was taken to perform this work. And through our quality audits, we saw, and the biggest convincing factor was physicians saw the resulting of these studies was as quality as what we were getting, if not more, in the past, in addition to being correlated with our inpatient studies or in-center studies. So PCPs, we have a lot of PCP customers in this community across our many regions that we cover, and they are demanding in the way that they want to see their patients' studies resulted sooner, and that rightfully so. So we went from turnaround times that were rather lengthy of 1 to 3 months versus now our PCPs are getting their results within an average of 4 days. Add on the delivery time of the USPS home delivery system, we are now 8 to 10 days. And that has been a little bit different than when patients were coming to centers, but the convenience factor has far outweighed the fact that we went from a 5-day average to 8 to 10. Again, that's because of the delivery from where our warehousing is located to where we are in Pennsylvania. And we are looking at ways to even shore up and shorten up those times as well. Next slide, please. So our in-house HST program was, as I said, cumbersome. And one of the things that our physicians were doing, interestingly enough, when we went out and asked them what it is they wanted, they said, well, we're ordering from your competitors because we want a program whereby we can direct ship to our patients and take out the hassle factor. So our current HST vendor, which was WatchPet at the time, did offer us that direct ship program, which has turned out to be, as I said, based on what volumes you saw and the number of patients we're reaching, a huge success in January of 2019. So we presented our new mail order program to our physicians and our site directors, and once they understood what it is that was available to them and what we were trying to accomplish, it has been a windfall of volume and patients that are now getting tested and treated. Next slide, please. In January, as I said, we started out January 14th was, I think, our go live date, and my one of the colleagues that works with me, my clinical care coordinator, she had launched the program after we both had done quite a bit of marketing and individual communication. And our access is now no longer limited by our geographic region, which is pretty phenomenal. We've actually received requests for tests in Texas, South Carolina, Maryland, Massachusetts, and that was not at all what we set out to do. We set out to meet the needs of our patients in our region, but as we have expanded this service, we continue to get more and more interest from the communities around us and even beyond our borders. Word of mouth has played a great part in others finding out from some of these other locations. So really we've no boundaries anymore that we were previously limited by in our capital procurement of 30-some devices for a health system this large, whereby now we can have as many as we want, as quickly as we want, and allow us the scalability that we're looking for and the convenience and access to care. Next slide, please. So one of the really exciting pieces of work that we're able to do with this work together with our partner Itamar and WellSpan is we are able to treat patients in their third trimester of pregnancy who have obvious risk for OSA, and this is happening with a screening and testing prior to either the visit that they've had with their physician or an order generated by the obstetric physician that they're working with. We have partnered with the service line in that we are doing a pilot right now with this, but one of the things that we knew we had to do better with these patients, because there's a short window of time to treat them in their third trimester of pregnancy for OSA, was to turn the device around very quickly. And the way we hope to do that moving forward is we've been given the option of a disposable device, which again limits the hassle factor for the patient, and that they wouldn't have to send the device back. So we are looking at that option for the obstetrics population that we're trying to treat for their sleep apnea in their third trimester of pregnancy, and the outpatient preoperative population as well, which is a huge population for us. And now with some of the guidelines that have come out regarding screening and testing before their surgery, this will help us also achieve that goal. We have some inpatient work going on whereby we're partnering with the Heart and Vascular Services to treat their patients with heart failure, AFib. As we know, there's great comorbidity to these conditions, and we have been working to expand that through the use of a sleep navigator. That's an initiative we're working on, is not yet implemented, but we have found that the patients who do receive a sleep test within the hospital admission tend to stay within our care versus escape our care when they leave the hospital. When we looked at our data in 2015, we found that out of 600 consults in the inpatient setting in a 600-bed hospital, that only 5 of those came for follow-up. So we clearly know we have a problem on the inpatient side with getting these patients to understand the severity of their illness. We're working with our physician on the stroke patient population as well to test those folks prior to discharge. So this is a great piece of work that's also happening as we speak. Future direction, and next slide. One of the things that we've understood to be very successful in some of the health systems around us when we share best practice, and we've done some site visits to understand what they're doing to keep their patients in care pathways, is the sleep clinic model, which we are exploring in one of our sleep centers, our largest sleep center in the region, and also we have developed an east and west type regional footprint. So we are trying to mirror that same sleep clinic in both the east and the west eventually. We hope by using a sleep clinic model whereby a patient comes from completion of their study on the in-center studies to see a practitioner, that they would then get preliminary results, receive DME in the same day, and go then for their future follow-up and come back to us at the sleep clinic. We found that with our pulmonary and sleep medicine, as most of you I'm sure have these challenges of our queues being long and our more complex patients are in their care. The access piece for those patients that are fairly straightforward are having great difficulty getting to see us in a timely manner, and we're losing the opportunity to care for them. So through our sleep clinic model, we hope to be able to keep patients in the care continuum and pathway. In telemedicine, we found that that's another option that we have for our APCs to follow up with patients as well as our physicians. And also, of course, then again, with the disposable home sleep testing device, that opens up a lot of new doors for us as well by eliminating the extra step of returning the device to us. So those are the highlights of our journey over the last few years, and I am happy to answer questions.
Thank you so much, Tammy, for that excellent and informative presentation. Audience, while we typically hold our questions until the end, although you can submit them anytime, and we welcome that, because Tammy has to depart shortly, I will go ahead and ask you, Tammy, a few of the questions that have come in. One of them is, what is the turnaround time, and can someone do this remotely?
So what is the turnaround time? I'm going to ask that turnaround time, I'm guessing, is from start to finish of the delivery of the HST to the patient and then resulting to the physician. The interpretation time for our sleep physicians is 24 to 48 hours. From the time of acquisition to delivery of patient and back to the PCP or ordering physician is approximately 8 to 10 days. And the reason for the extra time is because our warehousing is currently in Georgia, in Atlanta, Georgia. So we are using United States Postal Service to provide delivery. And our future goal is to provide this delivery possibly from a local warehousing versus from where it is currently. And we are in discussions currently about that. And then, of course, with the WatchPat, we can also, with WatchPat 1, which is a disposable device, that will also shorten the turnaround time because the patient can then throw it away. That said, we do have the option of FedExing these devices or overnight shipping, but we have not chosen to do so unless patients meet criteria for that because of the cost.
Someone else wants to know. Thank you. Excellent. Someone else wants to know, are you doing one night or 2 night studies?
One night.
Great. And then do you charge for the inpatient screening?
No, we do not. We are working that into our bundled care management piece of payment of patients in bundled care. And we also are just accepting the fact for those that are not in care bundles that we are not going to get paid, because for us in sleep, if you're speaking strictly about revenue, it is on the downstream and the halo effect of that with our DME, because we have our own internal DME to our organization, and also with all of the follow-up and care beyond that initial test.
Does the Itamar device record positional OSA?
I can get back to you on that, but I do believe it does.
And Loretta, were you wanting to jump in and say anything about positional OSA, and then we will move on to the next segment? Okay. Excellent. Well, thank you so much, Tammy.
You're welcome.
Actually, somebody just told us that the Itamar device does record positional OSA. So we've got that.
I wanted to make sure, and I apologize for baffling. I tend to let my expert leadership team of techs tell me those things.
Great, that's a good idea. Okay, well, thank you so much, Tammy. We appreciate you squeezing us into your very busy schedule. We have two more excellent presentations, thanks, to do. And before we get to them, we would like to share a word from our sponsor, CleveMeds. CleveMed's fulfillment service allows your sleep center to focus on study scoring and interpretation by outsourcing home testing logistics like scheduling the test, mailing monitor to the patient's home, patient education, and 24/7 support. HSAT studies record gold standard signals, including 2 effort belts and integrated actigraphy, using our SLEEPVIEW monitor, one of the smallest and lightest monitors in the world, yielding study success rates over 97%. With tens of thousands of tests done so far with our ACHT accredited fulfillment service, sleep centers are able to meet patient demand quickly while maintaining patient care and revenue. Gold standard data and easy-to-use monitor offer you the best of both worlds. I am now happy to introduce Loretta Colvin, ACNP-BC. Loretta Colvin is a nurse practitioner at SSM Health in St. Louis, where her practice focuses on treating sleep apnea and insomnia. Ms. Colvin has more than a decade of experience in the field of sleep medicine as a nurse practitioner, patient educator, public speaker, and program coordinator. She is a recipient of the American Academy of Sleep Medicine Excellence in Education Award. Ms. Colvin has served on interprofessional committees and as an education program presenter for many organizations from the national to local level, including the AASM, American College of Chest Physicians, and Missouri Sleep Society. In addition to her clinical practice, Ms. Colvin is an assistant professor at Maryville University, where she serves as coordinator for the Acute Care Nurse Practitioner Program. Welcome.
I'm sorry. I think I was talking while muted. So can someone tell me if you can hear me now?
We can absolutely hear you now. You're good to go. We can see your
Great.
first slide as well.
Okay, great. Thank you. My name is Loretta Colvin. I am a nurse practitioner and I work at the SSM Health System, which is, I work in the St. Louis region in St. Louis, Missouri. And I also teach nurse practitioner students in online environment. And am I controlled? There we go. I don't have any conflict of interest to report on this topic. So just a little bit of background for SSM Health. In the St. Louis region, we have 6 what I would call kind of historically private or community hospitals, and we have 2 academic hospitals, 1 adult and 1 pediatric hospital that are affiliated with St. Louis University. I'm speaking to our model within our 6 community-based hospitals, and I work out of 2 of those hospitals. Our sleep services are centralized in terms of management and resources. We do contract with a variety of vendors for our in-lab services depending on the site. And then our home testing is all centralized within the region. So we use a vendor for our mail order home test services. We use a traditional airflow oxygen saturation RIP belt model versus the NMR watch PAT model. And our vendor provides our mailing of the device, support to the patient while they have the device, they receive it back, upload the data, score it, and then it goes on to our physicians who provide the study interp. And our group manages the pre-authorization process, coordination of the referral, and getting it over to the vendor for them to then take over from there. So just a little bit about how this model works then. The provider like me will evaluate the patient and then determine that home testing is our next step and place the order within our EMR. We use Epic, which then that order goes over to the centralized team. In the clinic, when we're evaluating the patient, we can also give them a demonstration. We have a demonstration device there that we can show them. So some patients are curious, some patients are a little worried they won't know how to do it. And so it's a nice way to be able to show them that it's pretty simple and comes with instructions and everything. So that gives them a little more confidence if they're unsure. As we're bringing the patient to the checkout desk, we'll let them know if we're doing a home test, and then they go ahead and have the patient sign the consent forms for testing. And this helps us to reduce the wait time versus the alternative, which is if we don't see them in person, we have to mail them the consent for testing and then get it returned before we can send out the device, because this consent would also include the authorization needed for billing, insurance, and other needs from our legal team. Then at the regional level, our team does pre-authorization if needed or confirms it's not needed, and then sends the referral on to the vendor. The vendor then either completes the test, sends back the data for physician interpretation, or they communicate back to us if a test could not be complete, with either because the patient has not responded or the original attempt was unscorable or not completed, and then they can't get a hold of the patient to complete the test. So we have some people that will do it once, but they won't do it twice. And so we get all that information back, which then goes back to the referring provider or office to then document in the chart and decide next steps on whether they reach out to the patient or go from there. And then our physicians, their role is to review and provide the physician interpretation from the scored home test data, and they use online software through the vendor. And then they also transfer that report over to our EMR so that our information was in our EMR for our system to providers and teams to be able to see as well. So from my perspective as the provider, I wanted to list some of the advantages. I'm not on the business side, so I'm not talking the business advantages and the numbers and volumes on that end, but I want to talk about why I see it as helpful to the patients that I evaluate and care for. First, patient preference. Well, a lot of patients do like this technology. They like that they don't have to come into the lab, quite frankly. They've seen the pictures on Google and Facebook. They've heard the stories from others that are not always the most positive stories about having the glue in their hair and various things. And so they so some patients are hesitant to get tested for that reason. This offers them another opportunity to get tested so that they can determine they have sleep apnea and get on treatment, which is really our goal here. For some, it's cost. They're on high deductible plans, and when they compare the cost of in-lab and home, home looks a lot more attractive to them. We have the ability to offer 24/7, 365 testing. So we don't offer studies this one day of a week or whatever. So it's more flexible to patient needs. We get some patients that are caregivers, whether for a spouse or a family member or for children. They may be a single parent and they don't have anyone to cover for them at night, and they don't want to call in their resources for an outpatient test. They're going to save those resources for if they end up in the hospital for something. So it's nice to offer an option for them as well. And then there are those that just want to sleep in their own bed, and that's all there is to it. And so this gives them the option to test at home. We can also use it as a way to reduce the wait time to testing. The classic patient I give as an example is the patient who comes into me saying they're falling asleep while driving. I drive on the same roads as them, so I really don't want to be having them drive home from that appointment. So of course that's an awkward conversation, but also I don't want to think about how they, whether they do or don't followed my advice and cease driving until they are evaluated and treated and their sleepiness subsides. So I like the opportunity to get them more quickly tested than if we have a long wait time in the lab waiting for a bed to open up. And then I also see the advantage for those that come in for occupational referrals. I've been doing this for a while, so I've seen the days of when everyone was put on hold at work waiting for testing. Thankfully, we don't see that in our region as much anymore, but we still will have people for other reasons who might be on hold at work or have only a limited time to get their testing done because they're getting towards the end of their 90 days they were given to get testing and they haven't been able to get in. And so it's nice to be able to offer an option to get them tested more quickly. And I'm going to talk a little bit more about the occupational model in a few slides. There's some advantages to the program to think about. You know, I've had those patients who are the chronic no-shows that stand us up at the lab a couple of times. And it's nice to consider home testing as another option so that you're not offering them a bed in the lab again, wondering if they're going to come based on past experience, if they're medically a candidate for either test. So there's a little bit of an advantage for the lab to reduce the no-shows in the appropriately identified patient. And so the next one's probably not going to make sense to people, because for people who've been doing this a long time, you remember how the convenience of starting everyone on PAP in the lab and then transitioning them over to the DME. So you had a chance to offer a few mask choices and various things. Well, we don't see that model in the same way now, because now we're trying to meet accreditation standards that limit how many masks we might want to use in a night because of then the cleaning requirements and equipment exchange replacement requirements to maintain accreditation standards for sanitation. And so we're not using as many masks as we probably historically did. And we have more limits on what masks we might have in the lab. So one of the things that sometimes is nice is having them start in the DME world means they're getting their equipment through their insurance, and they may have options for other equipment. Now, the downside is they then have to be very careful to pick the right mask to begin with, or speak up if they didn't pick the right mask. And some patients are better than others at evaluating how well they're doing on their mask. And then it's also an advantage to have a home test program and for us, a mail order program for times of either anticipated or unanticipated downtime. We've gone through a transition with our software, which in our lab, which took our lab down for a period of time, and we couldn't do testing. It was nice to have an option for those patients where we were more time sensitive in trying to get their test results, to be able to offer them a home testing option as well. And then we're also in a region that was impacted by CMS's change to requiring accreditation to perform sleep testing and bill for testing, I should say. And so in the region, that impacted some sleep centers of not being able to keep their lab open if they didn't have their accreditation complete. And so they needed to then take the lab down, waiting for that. So home testing provides an advantage to that, as well as a backup in the appropriate patient. Obviously, some it's not appropriate for due to their comorbidities. When you're thinking about a mail order, you want to think about workflow because there's some things that you're used to doing when the patients come in that you aren't doing in the same way when they're not coming in to start their test with you like they would historically do in the lab. So the important thing is thinking about how they get their consent signed. If you can get it on site, great, but we can't really ask that of our primary care providers to think about getting a consent ahead of time. So thinking about, can you post your consent online so patients could download it if they were interested? Are you willing to email a consent to a patient? Some health systems are more open to that consideration than others. And then how do you accept them back? That's really sometimes the reason no one wants to email out is they don't want to get the email back and then have to worry about whether there are how that is a concern with privacy and other things. So our EMR patient portal actually allows patients to attach documents, and so we can actually receive back. For some reason, it doesn't let us send out, but it does let us receive back attachments, and so we use MyChart through Epic. And then you have to think about communication and managing the handoffs, and managing the handoff for urgent, for example, or for unusual situations, and how you communicate that with your vendor, and then how your vendor communicates back when unexpected things like test was not complete, and how quickly do you expect that? How long do you try to get hold of the patient before you cut bait and move on? Also, it's important for testing conditions to be noted, and this is an area where we've had to focus some communication with our vendor to make sure that when we have circumstances that are not a patient initially getting screened for untreated sleep apnea or are getting tested in a different way than our normal model, knowing that they're being tested in different conditions. So if we're using a DOT protocol for occupational needs with some sort of chain of custody in place, then we want to be able to document that in the physician interpretation report. If they're using a dental appliance, we want information on that, and so that the interpreting physician is aware this is not the baseline test, this is the treatment test. And then also if multi-night studies are performed, this is important information for us to know as well as we're a one-night model. And then integrating with the in-lab, we still have a lot of in-lab tests ordered, but not all of them are approved by insurance. So then we have to have a good process of identifying those that are likely to convert over to home testing so that we can identify them early and try to hand them off as quick as they can, because the person who does not benefit from waiting a long time for an authorization is the patient, who may be tired, not feeling well, may be losing motivation to get tested and treated because they're getting kind of worn down by the system. And so it's helpful to really think about that piece and try to figure out how you can integrate your two systems, even if you have two different teams working in those two environments. And then along that, how do you then get an update to your orders if a patient does not get in-lab authorization? What's the process for communicating that to your ordering providers? And then also, what's your process for being prepared at the time of the medical review? We have a process for a medical director review or their delegate. And how is your approval specifically for in-lab, or do you approve in-lab and, if needed, home testing as well? So then the team can go ahead and move forward with either one, depending on what insurance does and doesn't approve. And then thinking about the underinsured or the uninsured patient is important because this is a patient who does not have a lot of money stowed away to spend on healthcare. And the cost of testing and treatment of sleep apnea is not cheap. And so it's important to keep that in mind, that our goal is to help our patients in the long run. And if we can reduce their cost of testing to them in order for them to maintain more resources for initiating treatment, that's an important consideration. And so that's something I want to know if a patient has a high deductible and limited resources, or other considerations why home testing is going to give them more access to ultimate treatment. And also, we have some patients with high specialist copays. So they don't want to come see us ahead of their testing. And so this is a nice option to think about for making sure primary care recognizes the models that are available for ordering home testing and how that works, so they can talk through it with a patient who doesn't want to come see us first before testing. And then let me just touch on occupational screening for obstructive sleep apnea a little bit. A lot of people have concerns about chain of custody, and I definitely understand where those concerns come from. I balance that with knowing that often the patients I've cared for are underinsured. And so the perfect test may not be the realistic test for that patient. And so I've seen models where you might do a home test as the initial screen, because if the home test shows that they have an AHI over 20 and are going to require treatment, then now all of the future financial resources are really going towards treatment, unless something unexpected comes up. And so you've saved them a lot of diagnostic money so that they have the treatment money to be able to stay employed, which is very important to them, of course, especially when they're in underinsured or uninsured. So it's a good tool for sleep apnea screening with the right model in place for how you communicate that you're using DOT protocol, and how you then respond to those results. Now, if we get negative results, we deal with that differently, but positive results, it allows us to shorten the wait time and shorten the financial and reduce the financial impact. But I'm talking about a high pretest probability group. And the common model we see in our region is from prior recommendations through the Federal Motor Carriers Safety Administration, which we're looking at neck circumference, hypertension, and BMI, and looking at having two of those three positive findings will then trigger a DOT examiner to refer a patient to us for further evaluation. And I just want to point out a study that we actually did in a group of patients I cared for, which was consistent with other studies that had been published through occupational clinics. And what they found is if patients met 2 of those 3 criteria and were referred, in our group, over 80% had sleep apnea and over 40% had an AHI that was more than 20. And this was using 4% criteria. And I say AHI in quotes because, of course, it's not an AHI on a limited channel home test. But the whatever criteria you want to call it when that number was over 20. So almost half ended up being able to get diagnosed, see that they were going to need treatment to meet the requirements of the DOT examiner, and go ahead and move forward with treatment. So I like to mention that to people to think about, because sometimes people are very hesitant with this group, but you have to kind of think about the ones that are likely to have sleep apnea differently than the ones that are not likely, and realize that those that are of a high pretest probability, you can really help them in their needs for their occupation, to maintain their work and occupation. Another interesting group that I would like to mention is insomnia patients. I do behavioral therapy, so I get a lot of patients coming in with a complaint to the staff of insomnia that then they end up on my schedule. Now, some of these are actually not behavioral candidates. They are high pretest probability sleep apnea. They just didn't realize it. We screen them for sleep apnea and our suspicion is proven, and we go ahead and treat them for sleep apnea predominantly. But then we get another group that is kind of in the middle ground. They have a lot of sleep complaints. Probably more of it is a more pure insomnia away from sleep apnea. But at the same time, they have some sleep disruption, maybe some nocturia, maybe they have high blood pressure. They might not have a high BMI. They've got anxiety and depression, quite possibly. And but their sleep disruption and their subsequent frustration with their sleep and their insomnia is just gives this picture of a poor sleeper. Not a great candidate to send right into the lab, because taking them into a new environment means they may be an even worse sleeper. And so it's not always a great group where your first step is the lab. But at the same time, that's not always a group that you can say, I am fairly convinced that this is not sleep apnea. There's not a comorbid sleep apnea. So sometimes I will consider home testing in carefully selected patients to screen for moderate to severe types of sleep apnea where I might not clinically be able to detect that well, but I could see more information through a limited test performed in their home in an environment they're used to, and be able to see what their oxygen level does. Did they seem to have respiratory events, and get a sense. Now, it's not a great model for, of course, the upper airway resistance syndrome mild sleep apnea, where we may not detect that well with home testing. And so we might have to then follow up with an in-lab test. But sometimes we can wait on that. We can say, well, we didn't see really awful sleep apnea to suggest that this is the main problem here. So let's really focus on behavioral treatment, see how you respond, and revisit whether we're going to assess you for sleep apnea again in the lab, and at what point after some treatment of your insomnia to better stabilize your sleep. And then I want to mention telehealth. For us, our model is that we see patients in person first, and then we do telehealth for follow-up. So we're not at a point of offering home testing within a telehealth model personally, but I do want to mention models like the VA, which are very successful incorporating home testing into a larger model. And in fact, this year there was a nice article published within the Journal of Clinical Sleep Medicine on the VHA's program. So if you can go out and take a look at that, it's really interesting to see how they've been able to expand care, particularly into areas of less geographic access to care. You know, I'm in Missouri. We have a lot of rural areas that don't have great resources for accessing their big VA medical centers, maybe 2 to 3 hours to get in there. And so for them to not have to come in for testing and be able to start treatment locally through their community-based center or home is really a nice model for serving those patients when appropriate. Obviously, some also have comorbidities where it would not be appropriate. And some of our decisions on how our telehealth program is currently structured are based on state regulatory and payer requirements. This is always a consideration that you need to have with just because the technology allows you to provide a service does not mean that the healthcare system is very supportive. And so you always have to think about all the different stakeholders and what are the needs, and particularly on the regulatory side, can you do it without getting in trouble, and can you get paid for it, are always important factors as you're designing a program involving telehealth. And then the last thing to think about is population management. As we see more managed care models across commercial insurance and Medicare, then the incentive shifts away from a per test fee into a cost per person to serve their needs with healthcare. And then home testing starts becoming more attractive because now you're not making money off the individual test, you're thinking about the population as a whole and how to direct resources and spend the money most wisely with some limit to the resources. And so that's when home testing, really similar to the VA model I mentioned, it becomes more attractive. And I think we'll see more shifts towards home testing as the technology improves, shipping improves, and the payers have more motivation to streamline some of the regulatory pieces. And that may also have carryover into the state regulations that might impact this as well. And it's important, to kind of go back to the DOT example I talked about earlier, is that if we can help direct more resources towards treatment, that's really ultimately our goal, and because that's what helps our patients and their health the most. All right, so that's the end of my session, and let me know what you guys want me to do. Do you want me to have any questions now or wait till the end?
Thank you so much for that excellent presentation. Let's wait for the end and to do questions, but yes, we do have some good questions for you. Okay, before we move on to our last presentation and then on to our questions, we do have a quick word from sponsor Itamar Medical. As the awareness for sleep apnea and its associated health risk increases, the wait times for a PSG may increase and unintentionally exacerbate disease burden and reduce patient satisfaction. The WatchPat Direct program was designed to help reduce this backlog. It is also ideal for your remote patients or practices with limited staff or available capital for equipment. WatchPat Direct allows you to expand patient access quickly with no upfront cost and with minimal time and effort from your office staff. Once implemented, your office staff will have more time to care for the patients and the other critical activities to improve the practice's performance. If you have an interest in learning more about the WatchPat Direct program, please contact Itamar at info@itamar-medical.com. That's info@itamar-medical.com, or visit itamar-medical.com. It is now my pleasure to introduce Wendy Smith, RPSGT, CCSH. Wendy Smith is a registered polysomnographic technologist and certified in clinical sleep health with 19 years of experience. Throughout her career, she has worked in sleep center management, sleep research, and as an educator. Wendy currently manages sleep centers at WellStar Health System. Welcome, Wendy.
Thank you. Today I'm going to go over how a direct mail program improved workflow and access in a large health system. I'm going to discuss our journey here at WellStar, why we went with the mail direct model, and how it's impacted our program. There's a lot of similarities with both presentations. So for the spirit of, not having redundancy, I will just go through my presentation briefly and then take questions at the end to be efficient. I'm all about efficiency. All right, first things first, conflict of interest. I am a consultant with Itamar Medical. However, the purpose of this presentation is to help others take the best possible care of your patients and find the right home study program that fits your business needs. Just to give you a little bit information about who we are the largest healthcare system in the state of Georgia. We have rapidly grown over the last couple years. We purchased quite a few hospitals, and then we keep expanding and opening more hospitals and health parks for our patients. We now serve patients in Georgia and all of the surrounding states. Our sleep program, we currently have 13 sleep centers. We have about 15 sleep doctors. It kind of changes. We're always recruiting. We have over 50 allied sleep professionals. We have 12 county primary service areas. However, like I just said, we serve basically the entire state and all the surrounding states at this point. I manage the home study program for 9 of our locations. So when we started our journey, we had 5 sleep centers. Some were as small as 2-bed labs, and our largest sleep center at that time was 10 beds. At WellStar, our footprint grew at a very rapid pace, and as I said, we continue to grow. So, our purpose is to provide as many people, world-class health care in the most cost-effective settings. We truly strive, every day to improve access to healthcare services that make our communities healthier while offering value and controlling costs. That's pretty difficult to do in a large healthcare system, so we're always being innovative and looking for ways that, we meet all of our goals. With the Mail Direct program, we've improved our staff experience. If caregiver is happy, patients are generally happy. We've lowered the cost of care. We were able to get patients tested sooner, start treatment sooner, and we're able to provide care for patient populations that wasn't possible before we had a Mail Direct program. So while we started a program such as this, at the time, like I said, we had 5 sleep centers. We had a limited number of devices, and most of our locations, as most sleep centers, you don't have a lot of day staff if you're very small, like our 2-bed locations. So we only had night techs working at those locations. So we would have our patients come pick up the home study devices about 30 minutes after the tech arrived for work for the attended studies. So the workload was increasing, and we had to manage the devices. How many? Did a patient bring it back? Did a patient not bring it back? Sometimes we would have to cancel patients last minute, which obviously was a patient dissatisfier. And then, there's wait time associated with that. If you have a limited number of devices, then, you have to, schedule accordingly. And so the wait times were, beginning to be more and more of a problem. And obviously our techs, they, it wasn't a easy come in, just get, going with your patients coming in a little bit later. It was immediately go, get the home studies done before, your patients come in that are staying all night long. So initially, we had a mixed experience. We did accomplish a lot of things that we were trying to accomplish, but then we also had more problems come up. So initially, we partnered with a company that one of our sleep ENTs wanted. The company had a great business model on paper. All of our problems were solved, or so we thought. Our long wait times basically was non-existent at that point, which obviously was grand. We definitely expanded access to service for, any service area. We could obviously provide that service. And we did it with little cost. We didn't have to go out and buy new devices. Our physicians were happier because they were able to get their patients in sooner, therefore decreasing time to treatment. Patient feedback was mixed. They liked the convenience, of course. They didn't have to leave their house. But for some of our patients, it was difficult for them to understand the instructions. And then the company wasn't very customer service friendly, I would say. They had a wonderful model where, you put in a time, you're supposed to call the patient, supposed to work out great, but it did not work out so great. And then the company they weren't responsive to patients, and they were not responsive to us either. So our failure rate, we noticed, also went up. So whereas our volumes increased by a lot, 50% in the first month, we had a failure rate increase, which then, of course, you have to test the patients over. Then, you're actually not getting them to treatment any quicker. Then also we have patients, as Ori previously discussed, that needs the chain of custody. That vendor did not have that option. So going with that, we actually took away access for that patient population. And one thing I think is very important when doing a program like this in order for it to be successful is really having a partnership with the company and it being a true collaboration at all times. Oh, I don't think my presentation, there we go. So decision to use WatchPat Direct. As Ori previously stated, the device is so simple to use. It looks attractive to patients. It really looks attractive when I go and do community events. I used to think we have this little hand. It used to look creepy, but it draws in so much attention. And then they look, they're like, what is that? And then you tell them, like, this test for sleep apnea. And it really gets the patient intrigued and like, oh, well, I can do that. That's nothing. I could easily sleep with that on. So when we first started with NMR down this path, there was no WatchPat Direct. One of our cardiology groups actually wanted to use the WatchPat for their patient populations. So initially, our healthcare system ordered, I think it was 13 devices, and they basically just kind of sat there because even though like we had that one group, we had to provide a lot of education to our other providers that this is not just a cardiology sleep, device, that this is a great device for all of the patients, However, they didn't have the mail direct program at that time. The rep at the time, we worked closely together. He was very persistent. Was in here, I feel like every day, which I love. But, I would test it over and over, and I'm like, it's great. It's really great. However, the thought of going back to that model of our patient experience going down, our staff, experience, whether, if they think this is truly a great place to work, would definitely go back down. We decided to work together and, come up with what works to meet our needs. There we go. NMR has excellent customer service especially compared to the other one. We actually have another vendor now because, as most people are aware, insurance companies drive a lot of what we do, and so not all insurance companies is going to approve one device or the other. So we do have another vendor. I will say even now, there's the customer service is vital, and they provide excellent customer service. And so their willingness to build a custom ship program that met our needs actually led to the implementation of WatchPat Direct. We worked very closely together. We still work very closely together to, meet the needs of our patients, meet the demands of, what revenue you need to bring in while also, not increasing your staffing costs or having to buy more equipment. They have worked with us on quality. If you work in any healthcare system, we have to monitor quality, and patient experience, nonstop. So the benefit of a direct mail program, it increases the access, to services. Like I said before, we had a 50% increase in volume, so just the first month. We had a 42% increase in volumes over previous year, while also maintaining our in-center testing volumes. And I think that's important to note because a lot of leadership are worried about bringing in a home study device that's so easy to ship because they look at, how much money, you make on an in-center test. If you do your program, what I do right, you're actually going to drive both volumes with a direct mail program. Obviously, the time to treatment is greatly reduced. Our labor cost is significantly reduced. We actually now have Somnoware. We started using that. We implemented that last year. So with both of those, it's a cloud-based platform, and with the Mail Direct program, we're able to actually continuously increase our volumes without adding additional staff. So that's lovely. So the first year implementation, our failure rate went quickly from 8% to 2%. At the time, we had the two vendors. Like I said before, you have to have those for insurance purposes. The failure rate stayed high with the other vendor. Failure rate was very low with WatchPat. At the time, the reimbursement was a challenge, so therefore we didn't have that much of an increase. But we worked with ITMR, and they were, well, try not to say that I'm selling them, but they really help. They listen to what your needs are, and then they go out and they make sure that it happens. So on the second year implementation, we saw a 48% increase over a prior year. Patient satisfaction increased, and then education was vital for us. So that's one thing you want to consider for sure is, how big is your network? How are you going to educate not only patients, but actually medical staff? We have a navigator, plus there's all of the leadership team here. Actually, everybody on my team goes out and we, educate the offices. We speak with the referral coordinators often, and, that drives a lot of, success with getting the patients being tested properly. So where we are today, like I said, we implemented Somnoware, which has allowed us to increase volumes without increasing our staff. We currently have a 60% in-center volume and a 40% home study. However, that's continuously shifting. Both volumes are increasing month over month. However, we have a team here that actually looks at every home study order that comes in for appropriate testing. If it is not appropriate testing for that patient, then we actually send the doctor a message and ask them, to go ahead and submit another order and explain why the patient, needs to have this. So again, all of this, implementing this Mail Direct program and seeing more referrals coming in, serving more patients, actually is growing our attended study volume as well. And the reimbursement, we have 98% of WatchPat and 2% the other. So almost every insurance will approve the WatchPat device. Patients absolutely love this device. It's so simple to use. So they're able, obviously, to get tested sooner, and it's easy to use so that they're more willing to do it. With some of the other devices that we've used over the years, especially the first one, the patients would get it, and then it would just sit because you open it up, and when you're trying to instruct somebody over the phone or ask them, especially about cannulas, they don't, if you ask, was it placed correctly? They don't really understand, some of our, especially older patients, what it's placed properly even means. So this, it's not intimidating. So it's definitely the right model for us. Our team member experience, again, our night techs, they don't have to fool with any of the home study appointments. And, we have a team here that handles the home study, the Mail Direct for 9 locations. And we are fortunate that we actually are not far from the ITMR headquarters. So when we have DOT patients, we actually, so that we can place the bracelet, we just get the device from them, and then the patient comes in, and then they're able just to ship the device back. And actually, I'll speak on what's coming next on that, which is, I think, lovely that NMR's implemented. So here's just some of the things I think is helpful when you're looking at, quick, easy questions for your patients to determine if it's the right program for you. And this is one of our latest survey questions, or quality reports, is, was the initial phone call thorough and helpful for explaining a reason for calling? And then did the representative call the following day to assure receipt of the device? Was the representative thorough and explain how to operate the device? And then did the representative explain how the device would be returned? And then did you have to call the 24/7 patient helpline? You can see that if you have the right information and the right device, there's 91 to 92% of patients don't even have to call to get assistance with the device. And then would you recommend use of the device to your friends? As I think Loretta spoke on earlier, you see pictures or photos on social media, different things, and you hear people talk about, oh my gosh, I had to go for that sleep study. It was horrible. I didn't sleep all night long. I think it's pretty huge to then see where it's a sleep study. And here, would you recommend the use of this device to a friend? Almost 100% of people say yes. So some things to consider when you're looking at partnering with a direct mail vendor is, are they committed to the same quality and safety standards that you're committed to? Does your brand promise align with theirs? Are they willing and able and to, deliver that brand promise? And then are they also continuously improving their model and always focusing on exceeding expectations? We have very high standards here. And, what's really important is that you find a company that also has the same values and that they're always looking to exceed expectations as well. And then are they supportive to your efforts? One company we had before, they were the only time we really had any support from them is when we had an issue that we needed their assistance, to help solve or fix rather. You want to find one that is willing to support your efforts. So, like I said before, we feel like educating within our system is vital. Find a company that is also willing to help you with that. So what we're doing to continue to have continued growth and success, we have sleep navigator positions. We're hoping to have quite a few more by next year. Our sleep navigators, they provide education to patients, serve clinical teams outside of sleep, and we actually go into the community as much as possible. And like I said, we all do that. If you go out in the community, you get a lot of valuable feedback, and you're able to connect with people to truly make your communities healthier. We're working to increase sleep health screening for all WellStar patients. And of course, increasing your sleep volume and screening patients, treating more patients, is going to make your patients healthier even outside of their sleep issues. And then, we are also looking at disposable for inpatient population. I think it's everybody's mission is to, reduce hospital readmits. And that's all. Thank you.
Thank you, Wendy, for that excellent presentation. We're about to do the audience Q&A. I think we've gotten several questions several times, so let's see if we can at least fit those questions in. Audience, if you do have additional questions, please put them in the Q&A box on your screen. We'll do our best to get to them. Just a reminder that a PDF of the slide deck is available in the handout section of your control panel. And this webinar is being recorded. In the follow-up email you'll get tomorrow afternoon, we will include a link to the recording. And just a reminder to be sure to take the course evaluation, which will appear on your screen after the webinar ends. Wendy, I'll send this question to you. We've gotten quite a few people asking about how do you handle prior authorizations in this direct mail HST workflow?
So we have a centralized team that works all of the scheduling, referrals, authorizations for our sleep centers. So we have, and then we also have a home study team that works for me, and we work closely together on, as soon as the referral goes in, we make sure that they obviously know the cost and we get approval to move forward. At that point, then it goes to our authorization team. They obtain the authorization, and then we process it as soon as the authorization comes back. And we have Epic, and so we've just created workflows within Epic and Insomnia to where it's a very easy process for us right now, actually.
Wonderful. And then Wendy, can you say anything about what you all do, I guess because you, especially with two different HST vendors, to kind of minimize any failures of the home sleep test? Do you still do any educating in the lab, or do you leave that to the vendors to do?
No, we also do that. So when the patients see providers in the office, if they are seen by our sleep medicine physician group, then they're educated there as well. And then we also, touch base with the patients. We honestly don't have to do much just because all the instructions have been over the years. They've really tried to simplify them, make them easy. So we do provide education as needed. And we definitely make sure that the patients, feel comfortable with the level of education that they've received.
Wonderful. Loretta, do you have any information about the education that you all do? Do you do it yourselves, or do you leave that to your direct sleep testing vendor?
Our education would be limited to if patients ask. Everything else is actually through the vendor.
Okay, great. And I think you may have answered this on the chat for folks who are looking there, but Loretta, could you tell us how many nights your typical study is with the home sleep test?
We're doing one night.
Excellent. Wendy, are you all doing one night as well?
We do 2 nights on our commercial payers and 1 night on the non-commercial payers. The reason for that is that if there's a high suspicion of sleep apnea, but the first night comes back either inconclusive or not showing apnea, they are going to, or at least here, the insurance companies are going to require a second night with a home study device before they'll approve the patient to come in center.
Great. Loretta, would you know at your facility, are you all using the automated scoring, if that's available on your home sleep test, or your text scoring the device? How are you guys handling scoring? And I guess for that matter, how are you handling interpretations of the home sleep test?
That's not a question that I actually would know the full answer to. It's my impression, though, that we are not using automated scoring. I just can't say that with certainty. And our physicians review each home sleep apnea test.
Wonderful. Wendy, do you know if you're using the automated and or scoring it in-house?
So we do not do in-house. That's part of the contract. Our physicians then read the study as soon as it comes back. And again, we use Insomnia, so that way they only have to go into, one program. So no matter if it's, whatever in-center or home study that it is, they're logging into one place and they just go to their patient from there.
Fantastic. Wendy, do you also carry any on-site inventory of the home sleep tests?
Well, we do, but we actually do not ever use them. because we initially purchased some, but the mail program, CHIP program works so well for us. One thing actually I forgot to go back to and mention. So the one patients that do come here are our DOT, the ones that need the chain of custody. Itamar has actually come up with where they are doing video verification and where they have the patient, they show them the ID, and then they're actually, instructing them how to put the bracelet on. So that's a future thing that's coming our way. It's, I think, going to be pretty great.
If I
Loretta,
can
do you have in-house? Yes, go for it.
Yeah, if I can add, we don't have in-house, and I think the piece that you really have to think about for that to be successful, if you're trying to use in-house to reduce wait times, meaning like while the patient's there, they can take the device home, like if you have a clinic and sleep center together. So first, you need to be geographically in the same place. As I mentioned, we have a centralized pre-auth team. So our pre-auth team is not in the room next door. And so for us, we don't have that direct interaction with their pre-auth team to be able to say, hey, this is a person with this Blue Cross insurance or something. Will they need pre-authorization to get testing? That is the question you need to answer to be able to have a patient be in clinic and then take a device home with them the same day. Otherwise, you're asking them to come back a separate day scheduled, and then you have to think about whether that actually is a convenience to the patient or not. If you're in a mail order system where that may not really change the wait time much, you're asking them to make additional trips. Now, if you're concerned that they will need extra help in putting the device on, or you're trying to maintain chain of custody, those are a little different models. But there's for us, looking at it from a regional perspective, we don't have an on-site model.
Thank you so much. That was very informative. Well, in order to finish on time today, I want to conclude by saying thank you to our three presenters, our sponsors, CleveMed and Itamar Medical, and to our audience members. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions, and visit us at www.sleepreviewmag.com. Thank you for participating in this Sleep Review webinar.